I'm Catherine Reynolds. I'm one of the faculty members that teaches in the College of Nursing. I teach primarily at the senior level in what's called a parent-child course, so it's a semester long, and half of it is devoted to pediatric content in the classroom and simulation and clinical, and then the other half is focused on the childbearing woman in class and in clinical and simulation. So I am actually a 1979 graduate of the College of Nursing at Villanova. I wish I could say 1980. It sounds so much younger, doesn't it? Now don't do the math, okay? The younger generation needs their calculators. They can't. This is Dominic Villani, and she actually volunteered to come with me to give the student perspective on simulation. She is the rising star in this video. So she's the nurse coming in to take care of this 12-month-old child that you're going to see with asthma in the simulation setting. But probably you have all been involved in some level of simulation if you've ever done mock interviews or you've had fire drills or anything of that nature. But has anybody done anything more sophisticated in their high schools in terms of simulated learning that they wanted to? I think it's taking off at all levels. Did you?
We use it with phlebotomy with the big arm.
Oh, okay. So that is what's considered low fidelity simulation, where it's not in the context of a scenario, but you're practicing a skill, which is what was real common when I was first in nursing education at St. Mary's. We did a lot of role playing to practice communication skills, and that would be a type of simulation. And we did a lot of tasks and skills on task trainers. So now the thrust in nursing education is to always present within the context of a patient, always keeping the patient with you. So even freshman year, when you are practicing communication skills, it will be in the context of a patient who has a history, a past medical history, a history of present illness. So right away, you'll be keeping the patient with you, which is I think one of the advances, major advances in nursing education. So Dominique, do you want to explain to them what you think about simulation and your experiences?
Well, I'm Dominique. I'm a senior nursing student, and I'm in pediatrics right now. Dr. Reynolds is my clinical instructor. So simulation this semester, it's all about pediatrics, working with kids. This scenario you're going to watch, can you choose the scenario?
Yeah, go ahead.
Okay, so this scenario is a baby who is having respiratory distress, and we have to work in a team to figure out what exactly is going on, if there's anything that we can do to help fix it, if there's not, who the appropriate person to contact is, and also how we can talk the mom through the situation. And then afterwards, I'll tell you a little bit about how SimLab helps us out and how it differs from the hospital.
Has everybody had a tour of the Learning Resource Center on the first floor? If you haven't, you need to get down there and go into all of those multiple rooms. And hopefully you will feel like you're entering a clinical setting or a patient care setting. And you'll see the simulators. We have babies, we have 4-year-old size, we have adult size, we have birthing women. They
give birth.
They give birth. And then we also have what's called simulated, standardized patients. So that would be where we hire and pay and train people to be the actors or actresses as the patient or as the parent at the bedside or as the physician, whatever role we want them to play. So they go through a pretty rigorous, it's not easy to get that job. There are some students here who've applied for that job from other colleges, and they enjoy it. They learn a lot also, but they need some acting skills, and they need the ability to be kind of empathetic about what the patient's going through. So we could talk a little bit about that after. Okay.
Hi, Mrs. Bill. How's Jake doing today?
Oh, you know what, I think he was doing well, and now I'm just a little nervous. He doesn't seem to be doing great again.
Okay. We're going to do an assessment now. We'll check out, see how he's doing.
Thank you so much.
Okay. You sitting here with an asthma flare?
Yeah.
Voice sounds?
One thing I forgot to tell you that Dominique reminded me that I should tell you that I am in the control room. I am the one controlling the computer that controls the baby mannequin. So I can change the heart rate, the respiratory rate, the breath sounds. I can make the chest wall retract to show worker breathing. I can show nasal flaring, skin color changes. I can make the baby cry, have stridor. So I do have a lot of control up there. It's very much fun.
Okay, great. I'm right here if you need me.
His DSAT is also, or oxygen is at 85. Okay, so it's pretty low. We're going to actually administer oxygen now.
Oh, okay.
Start at 1 liter.
Okay.
Actually, what you can do for us is you can sit by and actually raise his back.
Oh, all right.
Raise his head up. Make it easier for him to breathe.
There you go. Okay, Jenny. Uh-huh.
As long as we're here and we're gonna go and see if there's an order for our
Okay, yeah, because he's really, seems to be working so hard.
He is filling in his chest area. So we're actually, when we pull this off,
Come on, Jake, you're doing fine. Good boy. And I'll just be pulling him up then, okay, sure.
Butyral inhaler, 4 puffs every 2 hours. Okay, so we're going to administer this. What this is, actually it's a bronchodilator,
Okay.
which means it's going to open up his airways.
Oh, yeah, we need to respond to this in the emergency.
Start at 1 liter.
Start at 1, so we're gonna raise it to 2.
Okay. All right, Jake. Okay. There you go. Breathe that in. Good boy.
How's he doing?
He's improving, but so I'm gonna raise it again to 3, and then that's the max.
Okay.
So right now, we've already suctioned him, we've done the albuterol treatment,
Right.
and increased his oxygen to 3 liters.
Okay.
His oxygen level is improving, it's 92, it's decreasing, so it's good.
That's better, right? Okay. Good. Good.
We have ways to help his breathing.
The next step would be actually to administer anti-inflammatory, but
Okay.
I guess that would be what should happen.
Okay, well, I'm gonna go ahead and call the doctor and let him know that we've done everything. I'm calling the doctor.
This is Dr. Smith.
Hi, Dr. Smith, this is Dominic, I'm here with Jake Miller. His pulse ox was at
Can you give a background, Jake?
Sure. Jake has an asthma exacerbation. He is 13 months old with 12 kilograms.
He came in last night or refresh my memory? So
He's just been transferred to the floor today.
Okay, and what is the assessment?
His breath sounds are coarse. His pulse ox was 88, but then we gave him 3 liters of oxygen, an albuterol treatment, and suction to his nares, which is now increased his pulse ox to 92. Heart rate is 124. Temperature is 35.7. And
Still shows work with breathing with substernal contractions, nasal flare as well.
He still has nasal flaring.
Yes.
His respiratory rate is equal to that.
54.
Okay. Did you reassess his breath sound yet to get out of your lung? Put a listening attitude.
His breath sounds sound clear on the left side and coarse on the right.
No easy.
Wheezing, no wheezing.
I think I'm gonna put an order in for IV outside your manual. I'll be up to see him in a minute, but let's do a little bit of chest PT on him. I'm gonna swing some out and that will help break up the mucus. He might have infection, which will have mucus production. No problem, thank you.
All right, so we're gonna give you a cough.
Okay. Here you go, Jake. Just tell him what that is.
Okay, so we'll show you
Here.
how to hear.
Okay.
Thank
Thank you.
Just cover your hand.
Uh-huh.
You just pat on the back, and it's going to break up all those thick secretions and cough them up.
Oh, great.
And also suction it up.
Okay, I'll give it a try. Thank you for coming on board.
Good, that's perfect.
All right, does that feel good? You're no better to me.
I'm going to grab the suction.
When the students debriefed on this, they realized that their technique for chest PT was not exactly what it should be. The baby's head shouldn't be bobbing. That actually is a sign of respiratory distress when the head is bobbing, but it was due to the fact that they were clapping probably on the wrong. But again, these students had never done chest PT. They never had the opportunity in clinical. They saw it in class, like a picture of it, and it's in their textbook. Until you go to do something, it doesn't become clear to you. So we talked about that in debriefing and practiced a little bit of that skill.
So also about debriefing, as you can see, that was not totally perfect, but it's okay. It really doesn't have to be. It has to just be like for you to learn. In the debriefing, you're going to go over where you struggled, where you could have improved. And these situations for your junior and senior year are not graded. They're just for you to learn from. So you don't have to have that stress of having a grade attached to it. You really have to just think of it as being a real scenario and reacting, and how you can help the patient in the scenario. A couple things I guess I wanted to talk about that you can be expected to do for these scenarios was patient teaching and incorporating the family. So throughout that whole scenario, you saw us always teaching the mom what we're doing, what medications we're giving, why we're giving them, how she can also be involved. So you have to, help the patient and also help keep the mom involved and help keep her stress low. Also, you saw us doing the assessment and following the orders, trying to help this baby improve his breathing, and realizing at some point, okay, we've done everything we can. Now, who do we contact, and what's appropriate to report to this person? So you have to think, okay, this situation, we're gonna have to contact the doctor, and this is what he needs to know. And you can even offer recommendations of what you think needs to be ordered, things like that you have to just be thinking through for these scenarios.
Trying to help students see who's part of the team, who do they need to collaborate with. It's not about knowing what to do all the time, but it's about knowing what you don't know and who to contact. So they're told beforehand that they can decide to contact whoever they need, whether it be pharmacy, social work, psychiatry, public safety, anybody that they know could be part of their resources, because they don't know what's going to happen in this scenario, and they need to think of, they're not there alone. Who would they utilize? And whether they're a new nurse or an experienced nurse, that all nurses are in situations that are unfamiliar to them. And the good nurse knows when they need help, who to reach out to, and who those resources are. So they get a chance in a lot of these scenarios to collaborate more with a team, maybe the respiratory therapist. We could actually simulate rounds on a patient where everybody involved in the care of that child, they go on walking rounds. So there's really nothing we can't simulate, and we can switch it out and make it simple to complex.
What's great about SimLab is that you are guaranteed to have to work through a crisis, but it shouldn't be stressful to you because it's a really safe environment. It's a 20-minute scenario. At the end of it, everyone's okay. And this is totally different than a hospital situation where if you were a student nurse, you'd have to take that observation role, and you'd have to let the RN who's employed by the hospital make these decisions. So you'd learn only through observing in a crisis situation. But here it's like, just kind of knowing your own abilities, knowing your skills, and really putting them to the test. So it's really valuable.
Some student comments were that it felt so real that they actually got anxious when the child developed cyanosis or had symptoms of allergic response, that they really felt like this was really happening to somebody. So that's what we're trying to create, where they're really immersed in the experience and really feel that they are equipped with the knowledge but need a safe environment to practice that, so that when they go into clinical, even if they don't take care of exactly this kind of patient, lots of patients have respiratory distress, lots of patients have need for teaching and parents by the bedside, so it's applicable to numerous clinical situations. There was one of the scenarios during this day is a 13-year-old girl with sickle cell disease who's having ischemic pain from vaso-occlusive crisis. Long story short, the student walks in the room and she is screaming and writhing in pain. And in reality, that is how some children with that problem can present. It's very uncomfortable for the students. They don't know where to start. They don't know how to calm the child down. They may not feel that they were that effective, but then when we debrief later and talk about what else could you, what were your other tools in your toolbox, they come up with, you know what, I should have done this, or I could have involved the parent, or, so they're the ones analyzing it at the end of the day and coming up with the alternative. So, it's not about making mistakes, but you really do learn from what you didn't do well, but we also emphasize all the things that they did well. So it's definitely a positive experience overall, I would say. That's what it's meant to be.
And they try to make it fun too. It's not, sometimes they just like to throw things out there. For OB, for obstetrics, they have a birthing sim doll, and you couldn't get it to calm down unless you specifically did this one thing. So you tried so many things and she wouldn't calm down, and then you did this one thing and she was good. And then we had a 4-year-old for pediatrics who, I forget what medication it was.
Had a fever, Tylenol.
Had needed Tylenol, so we called, because they even have like a Pyxis where you get your medication out of, and we're like, it's not in there, we need, we need the medication. They're like, oh, sorry, we only have a suppository available. So suppository is going up your butt. And so you had to explain to a baby or to a 4-year-old in words that he understood what you're doing. Oh my goodness, it was so funny watching them struggle through that. But I don't know if they got a kick out of it. I got a kick out of it.
We can have fun during simulation. Yeah. It's intense. It could be a long, draining day, but at the end, students feel like they took what they learned from one scenario, applied it to the next. So by the end, they're feeling more confident about applying that in real life. So any questions?
Make sure you check out the sim lab downstairs.
Yeah, you have to go.
Is the simulation matched with the courses that we take?
Yes.
I heard you say obstetrics and
Yeah.
so that's a planned curricular.
Right, so what you're getting in class is what you should be getting in the simulation lab, and then what you're getting in clinical.
So you'll always
Yeah.
have some kind of background in class to know what to work with.
And now with the ability to videotape, we can bring these into the classroom so that the 2 or 3 hour potentially passive learning environment becomes more interactive. So we can stop it, ask the student what they would do next. So there's an ability to bring simulation into the classroom. And that's pretty exciting.
You could control the baby screaming.
Yeah, I can, yeah.
That would be more realistic. Right?
Yes, I could have, and then if we have a live patient, like the 13-year-old who's live, obviously they can do it. And we have a ventriloquist, it's a special stethoscope that we can set the abnormal breath sounds. Because obviously when you have a healthy actress, she's not going to present with what we want her to present with should she have sickle cell disease. So we have ways to get around almost anything. Okay, well, thank you and enjoy your next session.
Thank you.